Welcome back to the Deep Dive. Today, we are cracking open the playbook for the worst possible scenarios, disaster nursing.
Hmm.
We're really diving deep into the specialized knowledge that transforms your core clinical skills into crisis response capability.
And that's the critical point, right? This isn't about the ideal scenario with all the bells and whistles.
Not at all.
This is about preparation, adaptation, and, maintaining competence when your resources are failing and the entire environment is just chaotic.
That's right. Our mission today is a comprehensive deep dive through the frameworks that govern major disaster response.
We're going to walk through it piece by piece,
Exactly. Starting with how communities even prepare, analyzing those complex command structures, and navigating some really intense ethical shifts.
especially around triage.
Oh, especially triage and rationing. And then we'll get into the clinical specifics of managing mass casualties, natural events, and I think most critically, the threats posed by weapons of terror.
And in any crisis, an effective response, it really begins with a shared, precise language.
A common vocabulary.
Exactly. Before we can even talk about action, we need to establish the vocabulary for the field.
Okay, so let's start there. Let's define what we even mean by a disaster.
Right, because it's so much more than just a bad day. A disaster is a sudden, calamitous event, could be natural, technological, man-made, that severely interrupts the functioning of a community.
Okay, and the key part is that it exceeds that community's ability to cope using its own resources.
That's the trigger. That inability to cope locally is what activates all the larger systems we're about to discuss.
And from that broad term, we often move to something more specific. The mass casualty incident, or MCI.
Right. And MCI is that specific moment where the number of casualties just fundamentally exceeds the available resources.
So not just people, but supplies, beds.
Staff, supplies, beds, even safe physical space. And that is the point where the true ethical and operational shift has to occur. It forces providers to move away from that individual optimal care model
To a population-based approach.
to the greatest good for the greatest number.
Exactly. We also have to be crystal clear on the progression of widespread disease, which has become so central to modern disaster nursing. Let's talk outbreak, epidemic, and pandemic.
An outbreak is the most localized stage, but it's already alarming. It just means the occurrence of a disease in a population that clearly exceeds what you'd normally expect.
So it's a statistical anomaly at that point.
It is. Now, when that localized problem spreads, it covers a wider area from a single source and starts having a really significant impact, we call that an epidemic.
And then the term that, became part of everyone's daily vocabulary a few years ago.
A pandemic, that's the global scope of the crisis, an epidemic that spreads across continents, sometimes worldwide, affecting a huge portion of the population. I mean, we all just lived through the most significant example with COVID-19.
And finally, the most alarming category of threat, weapons of mass destruction, or WMD.
Yeah, these are weapons designed and used specifically to cause widespread death and destruction. It's an umbrella term, really.
What does it cover?
It covers everything from blast injuries to the intentional deployment of biologic, chemical, and radiologic agents. And understanding how to manage those specific clinical scenarios is just non-negotiable for preparedness today.
Okay. Vocabulary set. Now let's pivot to the absolute necessity of planning, because the historical record is, it's undeniable.
Oh, it's written in every major catastrophe. Communities that anticipated scenarios, that had detailed practice plans.
They just did better.
They consistently demonstrated significantly better morbidity and mortality rates. I mean, it's not even a question. Planning saves lives.
So to standardize this preparation across the U.S., planning has to adhere strictly to the guidelines from the National Incident Management System, or NIMS.
NIMS is the blueprint. It's the nationally recognized framework for coordinating response. It's directed by FEMA and Homeland Security, and it provides that flexible, standardized structure that all government and non-government entities have to use to work together.
So everyone's playing from the same sheet music.
Supposed to be, yes,
Huh.
whether it's a hurricane or a terror attack.
And here is the operational reality check, that every local planner, every frontline provider, has to accept the mandate for sustainability.
Right. Local communities, and that includes hospitals, have to plan to function in complete isolation for a defined period.
And what's that benchmark?
The common planning benchmark is to provide competent, life-sustaining care for a minimum of 96 hours.
4 days.
4 days, before you can realistically expect any major federal or state resources to arrive and stabilize the situation. It means every hospital has to assume, from the jump, that they are on their own.
Wow. That 96-hour window really underscores why we rely so heavily on integrating all levels of government response. And that coordination is governed by the National Health Security Strategy.
Yeah, that strategy is basically the government's commitment to protect the health of all citizens, no matter the threat. Operationally, what that translates to is prioritizing the use of scarce resources.
Like ventilators.
Exactly, like ventilators or specific antivirals, and ensuring a rapid, effective, coordinated response that aims to minimize death and meet the basic health needs of the population.
So let's pull back the curtain on the actual players at the federal level. The
Mhm.
source material details these agencies like a massive response chart.
Okay, so starting with the public health pillar, the CDC, the Centers for Disease Control and Prevention,
What's their role?
they're the primary agency for disease prevention and control. They provide the essential intelligence, the lab capacity, and the backup support to state and local health departments when, the local system is just completely overwhelmed.
Then you have the behemoth coordinating agency, the HHS.
The Department of Health and Human Services, they're responsible for coordinating all health, medical, and health-related social services under the federal plan. They're the central hub.
And the military component is managed by the DoD.
Correct. The Department of Defense, they're the frontline military defense, deploying resources, personnel, infrastructure, you name it, to protect against acts of war or terror. And they often provide logistical support, like setting up field hospitals when civilian infrastructure is gone.
There's an agency that I think often gets overlooked in a crisis, the FDA.
The FDA's role is absolutely critical for supply chain stability. They're ensuring the safety and efficacy of drugs, devices, the food supply. We saw their unprecedented role during COVID with the Emergency Use Authorization, the EUA.
Right, that was a huge deal.
It was a massive policy shift. It allowed them to accelerate the review and release of diagnostic tests, vaccines, therapeutics. It showed a flexibility that was crucial in a national emergency.
And maybe the most hands-on federal resource is the National Disaster Medical System, or NDMS.
NDMS is the multi-agency system that coordinates the people and the assets for these federally declared emergencies. And within NDMS, you have the DMEDs.
Disaster Medical Assistance Teams.
Yes. These are self-sufficient teams of volunteer medical personnel. They can deploy rapidly and operate a field hospital or clinic for at least 72 hours, completely independently of the local system.
They're the cavalry.
They really are the cavalry.
And finally, when we're talking about threats, Homeland Security communicates risk through the National Terrorism Advisory System, NTAS.
Right. NTAS keeps the public and key infrastructure informed. They use bulletins for general trends or heightened risks without a specific target, but they issue alerts when there's a credible, specific threat.
And those alerts have levels.
They do. Elevated means there's a credible threat, and imminent means a specific pending threat is about to occur.
So to manage this huge network of players, everyone has to speak the same language. Which brings us back to the command structures, ICS and HICS.
The Incident Command System, ICS, it's the standardized, federally mandated structure for coordinating personnel, facilities, equipment, communication for any emergency.
So it's universal.
It's universal. It provides clear lines of communication, clear accountability, and crucially, in like a hazmat situation, it ensures prompt identification of the substance and the correct distribution of PPE to protect responders.
So how does a hospital adapt that for its own internal use?
They use the Hospital Incident Command System, HICS. It's the hospital-specific modification that defines the internal management roles needed to handle a surge. At the top, you have the incident commander.
Who has overall authority.
Right. And then you have supporting roles. You have a chief for operations, logistics, planning, and finance.
Okay, so break that down. What's the difference between the operations chief and, say, the safety officer?
The operations chief is managing patient flow and care delivery. Logistics is supplies and facilities. But the safety officer has a really unique role. Their job is to monitor all operations for unsafe conditions.
And they have real authority.
Immense authority. They can stop any activity they deem unsafe. It creates this productive, necessary tension with the operations chief who's just trying to push for speed.
And this whole structure is codified in the facility's core strategy, the Hospital Emergency Preparedness Plan, or EOP.
This is the disaster Bible for the facility.
Yeah.
And the Joint Commission demands that every facility create a comprehensive EOP. And this is the critical part. Practice it with all employees in mandatory drills at least twice a year.
If you don't drill it.
You won't remember it when the time comes. It's that simple.
So the very first step in building this EOP is the Hazard Vulnerability Analysis, or HVA.
The HVA forces the planning committee to be ruthlessly realistic. They have to evaluate the specific characteristics of their community.
Like what?
Are they next to a major highway, high flood risk, near a chemical plant, a nuclear facility, a major sports stadium? By identifying the most likely disaster types, the hospital can then tailor its plan and its stockpiles to the threats it actually faces.
Not just generic ones.
Exact.
And this all links back to that initial mandate we talked about, achieving that required self-sufficiency.
Precisely. We plan for sustaining core services power, clean water, essential meds, staff for a minimum of 96 hours, but you're ideally aiming for 7 days.
And that proactive planning has to include the hardest part.
Resource rationing. It means predetermining the protocols for allocating scarce life-saving equipment, like ventilators, before the crisis even hits. This is what prevents ad hoc discriminatory decisions under duress.
We all saw how quickly the supply chain just broke down during the initial COVID surge. It wasn't just staff, it was materials.
Oh, the insufficient supply of PPE, the respirators, face shields, gowns, that was arguably the single biggest operational failure. It led directly to the exposure and death of frontline workers.
So FEMA had to step in.
They had to implement a national 4-step plan focused on preservation, acceleration, expansion, and coordinated allocation of these critical resources. I mean, they were using the Defense Production Act. It just shows how high the stakes get when the global supply chain fails.
So let's get into the specifics of the plan. The source material outlined 12 essential components for a comprehensive EOP.
Okay, number 1, activation response. This has to clearly define how and when the response is initiated, who calls the code, where the notification comes from, and the chain of command that starts the clock.
2, internal and external communication. This is always the first thing to fail.
Always. So the EOP must outline redundant systems, radios, satellite phones, even runners, and a seamless flow of information between hospital staff, the command center, and EMS.
3, coordinated patient care. This is the strategy for managing the influx of casualties. It has to anticipate self-referrals, people who just drive themselves to the hospital, and establish clear pathways for triage, treatment, and discharge.
Number 4, security plans. Chaos is a guarantee. So the EOP has to coordinate security with facility staff and local law enforcement to control the environment, manage traffic, and protect resources.
5, external resource identification. You can't assume local help will be there.
Right. The plan has to list pre-vetted contacts and activation procedures for getting aid from mutual aid agreements, state stockpiles, and federal resources like DMATs.
6, people management and traffic flow. This sounds complicated.
It is. It's detailed strategies for managing all the groups converging on the hospital. Patients, the terrified public, the media, your own staff. You need designated areas and leaders for each flow so the walking wounded don't contaminate the critical care area, for example.
7, data management strategy. What happens when the EHR goes down?
It will. The EOP must include robust backup systems. We're talking low-tech solutions like disaster tags and paper logs to track patients, document care, and manage staff accountability.
8, demobilization response. This seems counterintuitive, knowing when to stop.
But it's critical. A single person has to be identified who decides when normal activities resume. You have to ensure you don't exhaust valuable staff and supplies by staying in crisis mode after the surge has passed.
9, after-action report and corrective plan.
The post-incident critique. It's essential. This debriefing identifies what worked and what didn't, leading to revisions of the EOP. And we have to acknowledge the delayed aftermath facilities often see an increased patient volume months later from psychological trauma or cleanup injuries.
10, practice drills.
And they have to be more than just tabletop exercises. We're talking full-scale regional drills coordinating the hospital, EMS, police, and public health, specifically designed to troubleshoot those communication failures.
11, anticipated resources, so actually stockpiling.
Yep. Beyond generic supplies, the plan has to anticipate specific needs from the HVA stockpiling food, water, and specialized countermeasures like antibiotics for biothreats or chemical antidotes like cyanide kits.
And finally, 12, education plan.
The whole EOP is useless if the staff doesn't know it. Every single employee, from clinicians to janitors, has to be trained on their specific role in that plan.
Knowledge, confidence, and readiness.
That's the goal of the 12 steps.
Okay, with the planning done, let's move to the front lines. The single most ethically charged decision point in disaster medicine. Triage.
This is where we sort patients. But before we even get to the ethics of it, we have to talk about the system of patient identification. It's vital for coordination and, for family reunification.
And that system relies on disaster tags and a centralized disaster log.
The tags are numbered, they're color-coded, and they are securely attached to the patient. They stay with them through everything. And the information on there is critical. Their priority, name, age, address, injuries, treatments already given.
And that tag number is key.
It's immediately recorded in the disaster log at the command center. That's how you track movements, assign beds, and provide information to anxious families.
Okay, now let's confront it. The fundamental ethical switch. Contrast normal, everyday ER triage with disaster triage.
Okay, under normal triage, the guiding principle is patient advocacy. We throw everything we have at the most critically ill individual. So a young person in cardiac arrest, they get immediate resource-intensive advanced life support. The goal is saving that one life, no matter the cost.
But when an MCI is declared and resources are suddenly scarce, that priority have to flip.
The ethical shift is profound, and it is difficult. The guiding principle becomes, do the greatest good for the greatest number. Decisions are no longer about what's best for the individual.
It's about maximizing population survival.
Exactly. Resources are conserved for those with serious but survivable injuries who have the best chance of making it with minimal resource use.
So walk me through that. I'm a nurse, I'm standing there, and a young adult comes in cardiac arrest. My instinct, everything I've ever been taught, is to jump on that. How do I mentally manage deciding the resource cost is too high?
It requires a conscious acceptance of utilitarian ethics just for that crisis period. You have to recognize that that patient in cardiac arrest who needs a vent, pressors, hours of staff time, blood products, they have a very low probability of survival.
And those resources could save others.
Those same resources could save 5 other patients with treatable tension pneumos or manageable hemorrhages. The nurse has to recognize that their ethical obligation has shifted from the individual to the community. In an MCI, that cardiac arrest patient becomes a low priority or expectant category.
So let's break down the color-coded tagging system for this rapid classification.
We use 4 categories. Priority 1 is red, or immediate. These are patients with life-threatening injuries, but they are survivable with minimal, quick intervention.
So what are we talking about?
Think fast fixes. Securing an airway, managing shock, stabilizing a sucking chest wound, controlling major bleeding. If you delay, they die. Simple as that.
Okay, priority 2 is yellow or delayed.
These patients have significant injuries, but they're stable enough that care can wait for several hours without a threat to life or limb. Things like stable abdominal wounds without major bleeding or fractures that need surgery, but can wait until the red patients are stabilized.
Priority 3 is green or minimal, the walking wounded.
Right. Their injuries are minor upper extremity fractures, small cuts, minor burns. Treatment can be delayed for hours, even days. The critical operational step here is to move them away from the main triage and treatment areas immediately. They can't be clogging up the system.
And the final, most difficult category, priority 4 is black or expectant.
These are patients with catastrophic injuries where survival is it's unlikely, even with maximum care.
Like what?
Unresponsive with massive head trauma, burns over 60% of their body, agonal aspirations, fixed and dilated pupils. They're separated, giving comfort care, but resources are not allocated for life restoration efforts.
Beyond this classic START method, we're also seeing more use of the SALT system.
Yeah, SALT stands for Sort, Assess, Life-Saving Interventions, and Treatment Transport. It's a newer system designed to be rapid and work for all ages. It emphasizes performing immediate life-saving interventions, like slapping on a tourniquet or opening an airway during the initial assessment phase, even before you assign the final transport priority.
So once patients are sorted, the hospital's internal machine kicks into high gear. And that means managing the immense pressure of external communication.
Accurate, controlled communication with the media and with terrified families is absolutely essential. If you don't manage it, their presence can compromise operations, breach confidentiality, and just lead to massive public confusion.
And this responsibility falls to one designated person.
The Public Information Officer, PIO, established under HICS. They are the sole designated spokesperson. The disaster plan must define a single, secure location for the media and ensure all initial statements are factual, focused on current efforts, and avoid speculation.
But the media can also be a vital tool, right?
Oh, absolutely. Media channels are crucial for mass public notification, telling people about quarantines, shelter locations, or where to go for prophylactic medications in a bioterrorism event.
Now, turning to families who are just experiencing the worst trauma imaginable.
They need a designated, controlled, and quiet area, safely away from the chaos of the treatment zone. And that area has to be staffed by professionals, social workers, clergy, mental health staff, whose only job is to provide emotional support and disseminate timely information.
The COVID-19 pandemic threw a huge wrench into this with visitation restrictions.
It was necessary, but it was deeply, deeply difficult. Hospitals had to strictly limit or ban visitors to reduce transmission risk and conserve PPE. The emotional toll of patients dying alone was just immense.
But there were some exceptions.
There were narrow exceptions for crucial cases: obstetric patients, those at the very end of life, or patients with developmental disabilities who needed a dedicated support person.
And technology filled the gap, sometimes pretty awkwardly.
We relied heavily on things like FaceTime and Zoom. But this exposed a real systemic weakness. The plan has to address socioeconomic disadvantage, right? It has to ensure you can provide access to that technology for vulnerable families who don't have a smartphone or reliable internet.
And in the face of all this stress, nurses have to integrate profound cultural sensitivity.
It's non-negotiable. A disaster affects every religious, ethnic, and cultural group at the same time. You have to recognize and adapt to cultural variables.
Like family roles.
Exactly, family roles, extended family, and decision-making. Recognizing that language difficulties can drastically increase a patient's fear. Respecting specific religious practices around treatment or diet.
And what about handling the deceased? That's a huge cultural flashpoint.
It is. The plan has to respect rituals for handling the dead. But at the same time, you have to address the clinical reality. For example, with anthrax, the need for cremation, because the spores survive, might directly conflict with traditional burial customs. That requires sensitive, immediate communication.
That brings us to the specific threat scenarios, starting with natural disasters.
These events, tornadoes, floods, earthquakes, they're unpredictable, they can happen anywhere, and their suddenness and scale often define the challenge.
What are the primary obstacles these events throw at the healthcare system?
It's a triple threat: immediate, widespread loss of communications, failure of clean water sources, and the loss of electricity. That combination is exactly why we have that 96-hour self-sufficiency plan. If you lose those three things, you are isolated.
And when a natural disaster strikes, patient arrivals follow distinct ways.
They do. The first wave is the minimally injured, the walking wounded. They get out on their own and arrive immediately, and they can potentially clog the whole system. The second wave, arriving within the first hour, is the most severely injured, the ones who needed rescue.
And the third wave is the one that really stretches the timeline.
The third wave arrives much later, sometimes 5 days to 2 weeks later. These are patients found in collapsed buildings or people who get hurt during the cleanup and recovery. It's a delayed strain on the system you have to anticipate.
Let's look at specific events. What defines patient arrivals after flooding or tsunamis?
Flooding gives you a mix of immediate trauma from debris and drowning, but the long-term risk comes from the unsanitary conditions. You see waterborne diseases like shigellosis, hepatitis A, or cholera popping up weeks later.
And for catastrophic events like earthquakes or building collapse?
The mechanism of injury is crush. The majority of fatalities are from crushing head and chest injuries. Survival for trapped victims hinges entirely on rapid extrication by search and rescue teams.
Volcanic eruptions present a pretty unique respiratory hazard.
The primary hazards aren't just lava, it's the ash, the cinders, and highly toxic gases like sulfur dioxide. So the injuries are often inhalation injuries and severe chronic pulmonary problems from all the particulate matter in the air.
And beyond the immediate trauma, what drives that delayed morbidity and mortality?
It's the breakdown of civil infrastructure. No water purification, no waste removal, difficulty managing human and animal remains, and no vector control. That leads to disease. And you have to remember, the responders' hypothermia is a huge risk for rescue workers in water below 75 degrees Fahrenheit.
Transitioning to pathogen threats, outbreaks, epidemics, and pandemics. How do we define the transmission threat?
It needs three things: a vulnerable population that lacks immunity, a highly infectious disease agent, and an efficient mechanism for large-scale spread, like through the air.
What criteria have to be met before an infectious disease emergency requires the full national response we've been talking about?
There are 5 key criteria: a huge number of projected cases, the disease causing significant disability or death, a high potential for social and economic disruption, local officials being unable to manage the resources, and crucially, the risk of international spread.
Let's look at the lessons from SARS-CoV-2. Our understanding of that virus evolved so much during the crisis.
It really did. Initially, we thought children were relatively immune, or at least didn't get as sick. We quickly learned they were infected at similar rates, but their symptoms were just often milder at first. That difference in presentation led to miscalculations in early planning.
And this led to the recognition of a terrifying new consequence: multisystem inflammatory syndrome in children, or MISC.
MISC typically appears weeks after the peak of cases. It causes significant inflammatory changes affecting multiple organs: the heart, lungs, kidneys, brain.
Huh.
And while most kids recover, it can be very serious, causing systemic shock. It just shows that the disaster isn't over when the first wave passes.
That continuous evolution of threats brings us to the most complex scenarios: managing weapons of terror, or WMD. Let's start with blast injuries.
Blast injuries are a high-incidence terror tactic, and the scene of a blast is always an active crime scene, which requires coordination with law enforcement. The injuries are often non-obvious, so you have to be vigilant.
What are the hidden hazards for responders at a blast site?
Well, besides the obvious building collapse, responders face the risk of secondary devices, which are designed to injure first responders. There's a risk of contamination if it's a dirty bomb, and disturbingly, the potential for terrorists to be hiding among the patients.
Let's review the 4 distinct phases of blast wave effects, starting with the immediate unseen damage of the primary phase.
The primary phase is from the overpressurization wave hitting the body. It mostly affects air-filled organs. The most sensitive part is the tympanic membrane. TM rupture is the most common primary injury. More severe effects are blast lung and hollow organ perforation.
Then you have the obvious physical trauma.
The secondary phase is from debris and shrapnel acting like high-velocity projectiles, penetrating injuries, amputations. The tertiary phase is impact trauma, when the wave physically throws the victim against something, causing fractures and head injuries.
And finally, the quaternary phase.
That covers all the complications: burns, crush injuries, smoke inhalation, and the worsening of pre-existing conditions like COPD or heart disease from the stress.
Let's focus on the big clinical emergency from the primary phase: blast lung.
Blast lung is caused by the pressure wave rupturing the alveoli. It leads to hemorrhage, edema, and a massive VQ mismatch. But the most terrifying complication is the creation of air emboli, which can travel to the brain or heart and cause sudden death.
So what's the rapid management for a suspected air embolus?
Time is everything. The patient must be immediately placed in the prone left lateral position to try and trap the air embolus in the apex of the heart, followed by emergent transport to a hyperbaric chamber.
We mentioned tympanic membrane rupture as the most frequent injury. What are the signs?
Hearing loss, tinnitus, ear pain, dizziness, otorrhea. Most of these will heal on their own, but they are a critical warning sign that the patient was exposed to a significant primary blast wave and needs a very thorough assessment for internal injuries like blast lung.
Moving to biologic weapons. Their threat is high because the agent is often invisible and hard to contain.
They're easily obtained, easily spread, often as an aerosol, and they result in high mortality. Since the initial symptoms often mimic the flu or a cold, clinicians have to maintain a very high index of suspicion.
What are the immediate management priorities for a nurse facing a potential biologic attack?
The sequence is rapid recognition, ensuring proper PPE is used, decontamination if needed, implementing strict isolation quarantine, and then the timely administration of specific vaccines or antibiotics.
We should focus on the high mortality category A agents. Let's start with anthrax.
Bacillus anthracis is the agent most often talked about for weaponization. It's a spore-forming bacteria. It's odorless, invisible, and can travel huge distances as an aerosol. But here's a critical nursing point. It is not contagious person to person.
So standard precautions are enough.
Standard precautions only for staff.
Okay, detail the lethal form. Inhalation anthrax.
It starts deceptively, just like the flu fever, cough, malaise. There's a brief period where they seem to get better, and then a sudden, devastating second stage. Severe respiratory distress, hypoxia, shock, and usually death within a day or two. The clinical hallmark on a chest x-ray is hemorrhagic mediastinitis.
That widening of the mediastinum.
From bleeding and swelling of the lymph nodes, it's virtually pathognomonic.
So given the near 100% mortality once that severe stage hits, what's the management focus?
Early, aggressive treatment with long courses of antibiotics, ciprofloxacin, and doxycycline for 60 days. The 60-day course is because of the long incubation of the spores, and post-death, cremation is recommended because the spores can survive for decades.
Next, smallpox or variola. A
Ah.
terrifying threat because global immunity is so low now.
It's highly contagious, direct contact, droplets, contaminated linens. The key diagnostic feature is the rash. After the high fever, a maculopapular rash appears, and all the lesions progress through all stages at the same rate. It starts on the face and forearms, then spreads to the trunk.
What's the isolation required and what's the prevention strategy?
Strict airborne and contact precautions in a negative pressure room are mandatory. The patient is contagious until all the scabs fall off. The most effective prevention is vaccination, which works if you get it up to 4 days after exposure.
Now let's move to chemical weapons. These are overt, the effects are immediate, and they require rapid decontamination.
Right. Chemical agents are defined by a few characteristics. Volatility, how fast they vaporize, like cyanide; persistence, how long they stick around on surfaces, like mustard gas; toxicity; and latency, which is the time delay between absorption and symptoms.
And what are the universal management principles?
Evacuation from the area, immediate removal of all clothing that removes 80 to 90% of the agent, and then rapid decontamination with tons of soap and water. And staff must wear PPE and contain the runoff water.
Let's detail the 4 types, starting with vesicants or blistering agents.
Agents like lewisite and sulfur mustard. They cause superficial to partial thickness burns, especially in warm, moist areas like the axilla or groin that turn into painful blisters. The mortality comes from the delayed respiratory effects like chemical pneumonitis and ARDS.
And the decontamination for those.
Copious amounts of soap and water rinsing. But no scrubbing, because that can drive the agent deeper. And no bleach. Sulfur mustard exposures have to be watched for a full 24 hours because the respiratory symptoms are often delayed.
Next, the most toxic agents known. Nerve agents, sarin, soman, VX.
They're highly effective and rapidly absorbed. They irreversibly bind to acetylcholinesterase, which leads to a massive buildup of acetylcholine and causes a continuous hyperstimulation, the cholinergic crisis.
What are the signs of a cholinergic crisis?
Excessive secretions, that's the hallmark. The definitive signs are bilateral meiosis, pinpoint pupils, and then copious salivation, lacrimation, urination, emesis, uncontrolled bronchospasm, muscle fasciculations, seizures, and then respiratory arrest.
So treatment has to be immediate and specific.
Immediate. Decontamination with soap and water blotting the skin, not wiping. The primary antidotes are atropine, given IV to block the acetylcholine and dry up secretions, and pralidoxim, or 2PM chloride, which you need to reactivate the enzyme before the bond becomes permanent, and you need diazepam for the seizures.
The third type, blood agents focusing on cyanide.
Cyanide gas is incredibly fast-acting. It inhibits aerobic metabolism and just starves the cells of oxygen. Cellular asphyxiation. It can smell like bitter almonds and is often released in house fires from burning plastics.
How fast is the onset?
Terrifyingly rapid. Inhalation causes flushing, tachypnea, tachycardia, stupor, coma, and then quickly progresses to respiratory and cardiac arrest.
So the antidote regimen is life or death based on speed.
Absolutely. Immediate intubation and ventilation. Then the sequential antidote, amyl nitrite and sodium nitrite, followed by sodium thiosulfate. The alternative, hydroxycobalamin or vitamin B12, is being used more now because it's a bit safer.
Finally, pulmonary agents like phosgene and chlorine.
These just destroy the pulmonary membrane, causing massive capillary leakage into the alveoli, which results in severe non-cardiogenic pulmonary edema. Phosgene is really insidious because it can smell like freshly mown hay, but the edema is often delayed for hours.
What's required for staff protection and patient management?
Staff just need a particulate air filter mask. Patient management is all about getting them to fresh air, aggressive airway management, and supportive ventilation to handle the overwhelming pulmonary edema.
Our last major threat is nuclear radiation exposure, including from a dirty bomb.
A dirty bomb is all about widespread contamination, not nuclear fission. And exposure minimization comes down to 3 basic principles: time minimize it, distance maximize it, and shielding.
Can you clarify the 3 types of radiation particles?
Sure, alpha particles are easily blocked by paper or clothing, but are highly dangerous if you inhale or ingest them. Beta particles penetrate moderately, they can cause skin damage, and gamma and X-rays are highly penetrating, requiring significant shielding like lead or concrete.
We have to differentiate between the three types of injury: irradiation, contamination, and incorporation.
External irradiation means the radiation just passed through the body. The patient is not radioactive and needs no special isolation. Contamination means the radioactive material is on the patient's body or clothes. This requires immediate medical management.
And incorporation.
That's the actual uptake of the material into the cells and organs, the thyroid, kidneys, bones.
And if the threat is radioactive iodine incorporation, we have a prophylactic option, right?
We do. Giving stable iodine, or potassium iodide, Ki, can block the thyroid's uptake of the radioactive iodine, which is crucial protection for that organ.
Let's detail the steps for the decontamination protocol for a contaminated patient, which starts before they even come inside.
Triage and the initial survey have to happen outside the facility. Inside, the hospital must restrict access, cover floors, seal air ducts, and manage contaminated waste in those special yellow and magenta canisters.
And staph protection is paramount.
Full protective gear. Water-resistant gowns, 2 layers of gloves, masks, caps, goggles, booties, and personal dosimetry devices to track their own exposure.
So what are the 2 steps of patient decontamination?
First, they're surveyed with a Geiger counter, and all clothing and jewelry are removed. That gets rid of up to 90% of the contamination. Then, they're rinsed with water. The second step is a thorough soap and water wash and rinse.
And there's a key point about wounds.
Critically, any open wounds must be irrigated and covered before the total body wash to prevent incorporation, and you repeat the process until the patient is verified free of contamination.
And finally, the course of illness after a high-dose exposure. Acute radiation syndrome, ARS.
ARS follows a predictable course. The prodromal phase with nausea and vomiting, the latent phase where they feel better but their blood counts are plummeting, and then the manifest illness phase with infection, bleeding, and shock.
Which body system gives us the earliest and most critical indicator of how bad the exposure was?
The hematopoietic system. The best predictor of outcome is the absolute lymphocyte count, ALC, at 48 hours post-exposure. A count below 1,200 indicates significant exposure, requiring immediate barrier precautions for severe immunosuppression.
What about the central nervous system?
CNS symptoms, like cerebral edema, are only seen with lethal doses greater than 1,000 rad. This means imminent, irreversible death, and it often presents before the hematopoietic symptoms, which forces an immediate triage decision.
And how are ARS patients categorized in an MCI setting?
Probable survivors have minimal symptoms and are discharged. Possible survivors have nausea and vomiting that persists, followed by leukopenia. They need barrier precautions and aggressive supportive care. And improbable survivors are the black triage category.
So anyone with acute onset of vomiting, bloody diarrhea, shock.
And especially any neurological symptoms. Decontamination is required, but then care shifts to comfort measures. The dose was lethal and irreversible.
We've navigated the battlefield. Now let's discuss the soldier, the nurse's role, ethics, and behavioral health.
Disasters necessitate an expanded nursing practice. With the surge in staffing shortages, nurses might be required to perform advanced skills outside their typical scope, managing vents, intubating, or even serving as triage officer.
And that expansion leads directly to profound ethical tension.
It's the core conflict between the traditional patient-centered approach, doing the most for one individual, and the necessary public-focused approach, ensuring fair resource allocation for the whole community. It's a huge shift.
This is starkest in rationing dilemmas. Let's go back to that difficult scenario. TC, the 55-year-old essential worker, versus EW, the 22-year-old nursing student, and there's only one ventilator left.
This is the nightmare scenario. If we choose TC, EW dies, losing decades of potential life and future contribution. If we choose EW based on potential years saved or future service, we're devaluing the life of TC based on age and role.
So what's the answer?
The point is that these protocols must be predetermined, fair, explicit, and absolutely void of discrimination. Nursing ethics have to support that predetermined, community-focused decision, as painful as it is.
These dilemmas, combined with the extreme environment, lead directly to moral distress and self-care struggles.
COVID made this universal. Nurses experienced intense moral distress from watching patients die alone or having to withhold life-saving treatments because of shortages. And the struggle to balance professional duty with personal safety, especially with a lack of PPE, led to profound burnout.
Organizations also have to acknowledge that sometimes a nurse may choose not to respond. What's a valid reason for that?
Valid reasons include being part of a high-risk population themselves, like being immunocompromised, or grave safety concerns due to a lack of PPE, or a lack of institutional support for things like childcare. Organizational support, or the lack of it, is the single biggest factor in retaining staff during a crisis.
And finally, we have to manage the psychological disaster, behavioral issues, and psychological trauma.
Disasters inevitably cause stress, anxiety, fear, leading to long-term responses like compassion fatigue, PTSD, substance use disorder, depression, and somatization, those unexplained physical symptoms.
Who are the highest risk populations for psychological trauma?
Healthcare personnel and first responders are at the very top of that list. Also highly vulnerable are older adults, children, and anyone who is exposed directly to the dead or severely injured.
So what are the key nursing interventions to mitigate this trauma?
Active listening, providing emotional support, ensuring timely referral to mental health services, discouraging that repeated sensational media exposure, and actively encouraging a rapid return to normal social roles and support networks. And for the responders themselves, there has to be a structured support system in place. We call it Critical Incident Stress Management, CSSM.
CSSM is that comprehensive approach to prevent and treat the emotional consequences for responders. It has 3 phases.
Phase 1 is education before the incident, teaching coping skills. Phase 2 is field support. During the incident, making sure there's mandatory rest, food, hydration, and rotation. And Phase 3 is debriefings and diffusings. After the event, structured group sessions to process the trauma.
One final crucial consideration is caring for vulnerable populations, particularly those with disabilities.
The disaster plan has to specifically address their needs. People with disabilities rely on specific support networks, backup power for equipment, and pre-established evacuation plans. Shelters have to be accessible and accommodate service animals, and you have to make special efforts to keep those with vision or hearing impairments informed.
This has been an incredibly detailed and, frankly, pretty sobering deep dive into what it means to practice disaster nursing. Let's quickly recap the essential clinical takeaways.
First, remember that fundamental ethical shift in triage, from maximizing good for the individual to maximizing survival for the greatest number. Second, EOP and the drills are paramount. You have to practice the communication systems until they work under pressure.
And third,
For WMD patients, staff safety via PPE and decontamination is the immediate priority. That comes first. Followed by the rapid administration of specific antidotes, atropine and pralidoxim for nerve agents, Cipro for anthrax, and the fast antidote regimes for cyanide.
we've established that in disasters, survival really hinges not on heroics, but on pre-existing systems, mutual aid agreements, and anticipating the unimaginable.
And that anticipation brings us back to that concept of latency in chemical exposure. Consider an agent like sulfur mustard, where the visible effects are delayed for 2 to 18 hours.
So initial triage might miss them.
Exactly. If initial triage only catches immediate symptoms, how does a decentralized system guarantee that a patient who appears fine but was exposed returns for life-saving treatment once severe respiratory symptoms show up days later? That failure point, the patient who walks out and crashes at home, that's the ongoing challenge of preparedness that demands constant vigilance.
Integrate this critical knowledge into your clinical readiness. Thank you for tuning into this deep dive.